Wonderful. Well, good morning and welcome, everyone. Thank you for joining us for our annual board review course for ACP. My name is Ananth Shenoy. I'm an outpatient internist, and I have the privilege of helping coordinate this series each year with my co-host, Dr. Rachel Safran, who will be joining us later today. One of the things I just want to remind everyone, at the end of the course, we will ask for evaluations, and that is very, very helpful to us when we're looking at identifying speakers for next year and looking at content areas. With that, without further ado, I'm going to turn it over. We have the privilege and we get to enjoy Dr. Allison Bays from the University of Washington, who will be covering a lot of different uh, areas within rheumatology and the musculoskeletal system. And this is a particularly high yield part of the internal medicine boards. One thing I'll say very briefly, I will show you the blueprint if you want to get an idea of the breakdown of which content areas within internal medicine get covered a little bit later this morning. So Dr. Bays, we will turn it over to you.
Great. Thanks so much. I'm really excited to be here with you all this morning. We're going to do a race through rheumatology, and we'll try to keep it a little bit fun. There are lots of questions to kind of break things up. So let's get started. We are going to talk. So we kind of have this broken up into two parts. So the first part is kind of more some musculoskeletal, rheumatoid arthritis, gout, and then the next part we get into lupus and systemic sclerosis and things like that. There are also a few kind of at the end of the talks, a few extra resources for you to kind of look through things on your own as well. So the first thing we're going to do is talk about synovitis, and this is important, for the boards, but of course for clinical practice as well. And so in rheumatology, we really break it up into these three main patterns. So what we often are looking for in rheumatology is morning stiffness. So that tends to be more than 30 minutes in inflammatory arthritis, but often even several hours. The patients will say, I woke up, I had trouble moving, I was very stiff, and it took, a while for me to start moving around a little easier. Tends to improve with activity. Sometimes people will say once they're in a hot shower. Swelling is common, and we're looking for swelling or increased warmth in the joints. And kind of the classic pattern of inflammatory arthritis is rheumatoid arthritis. In terms of mechanical joint pain, that's kind of more 10 to 15 minutes of morning stiffness. So maybe you wake up and you're a little stiff, but really the pain comes with use over time. So people who are overusing it, overdoing things. And the kind of classic one, of course, is osteoarthritis. Tendinitis can be part of that as well. Fibromyalgia has a lot of different symptoms. So people will come with pain, but they'll also have a lot of other complaints, including non-restorative sleep, fatigue, memory difficulty, and pain up into about 19 different areas. So you can see the kind of the dots highlighted there. And then exercise intolerance are feeling kind of wiped out. So the first thing we always do is kind of start separating these things into these different buckets. And then we're going to talk a little bit about the differentials. So for monoarticular arthritis, we think about inflammatory or mechanical types of arthritis. And you'll notice, so inflammatory, we've got in addition to our autoimmune things, we have infection, crystals, and mechanical as well. So infection, there are a few different organisms. So staph or strep, gram-negatives. Gonorrhea is rare, but the boards like to ask about it. And fungus and tubercular infections. Sometimes there's a sinus tract of the skin with fungal infections. We're going to talk a lot more about gout and pseudogout, as well as psoriatic arthritis and other autoimmune conditions. And then mechanical, so there's osteoarthritis, wear and tear arthritis, of course, trauma, and then osteonecrosis, which can also be sometimes secondary to other things like our steroids given for our autoimmune disease, for example. In terms of kind of oligoarticular arthritis, which we think about as a few joints, but not over five, we have Lyme arthritis. So that kind of entails recurrent large knee infusions, sometimes bacterial as well, especially if someone has multiple, if someone's systemically ill and bacteremic. There are other conditions like polymyalgia rheumatica, spondyloarthropathy, sarcoid, chronic arthritis, and of course, crystalline arthritis, and then mechanical osteoarthritis as well. So kind of more joints. So when we're thinking about polyarthritis, multiple joints involved. So there's really a differential for that as well. So we think about viral infections, parvo, hepatitis, our autoimmune conditions typically cause polyarthritis. Of course, they can cause lower numbers of joints involved as well. But if you have a lot of joints involved, we're thinking about rheumatoid arthritis, sometimes lupus, Sjogren's, psoriatic arthritis, of course, osteoarthritis, and then serum sickness as well, reactions to medications. The differential of a very painful joint, so someone who has really extreme pain doesn't want you to touch or move their joint. Bacterial arthritis or gonococcal arthritis. So we kind of separate this out into BBC, bugs, blood, and crystals. So there's bugs, so those are the bugs, blood, due to often an ACL tear, an interarticular fracture, meniscal tear, anticoagulant use, or hemophilia. And then crystals, of course, gout and pseudogout, which we'll talk a lot more about. And if you see fat floating on blood, that's indicative of a long bone fracture. Okay, so we're going to go into some of the common musculoskeletal issues that show up on the boards. And we're going to go ahead and have our first question, and then we're going to, go through and talk about them all. Great. Okay. Well, there's quite a breakdown, so let's talk about it. No one shows E, which is excellent. So this is a rotator cuff tendinopathy. So we want to talk about the differential of shoulder problems. So if you have profound stiffness, especially like we talked about stiffness in the morning, that tends to be consistent with polymyalgia rheumatica, or sometimes rheumatoid arthritis. And so that's more of the inflammatory causes. With pain and limited range of motion, we have glenohumeral osteoarthritis as well as adhesive capsulitis, versus if someone has mostly weakness. So the things we think about more weakness is myositis. Sometimes you can get pain involved, but the predominant feature is going to be more myositis. We also have cervical radiculopathy as well. And so someone should, potentially have a lot of nerve complaints as well. In terms of pain with movement, we have rotator cuff pathology. And so someone may be weak with a rotator cuff tear, and AC joint arthritis. So pain with cross body adduction. So putting your arm kind of across your body and then kind of putting some pressure on that. In terms of the rotator cuff, it stabilizes the glenohumeral joint and helps perform internal and external rotation and abduction. So as we know, we have the subscapularis, the supraspinatus, infraspinatus, and teres minor. So in terms of rotator cuff, this is very common, of course, not isolated to autoimmune disease, wear and tear. It tends to be, in someone who is over 50 years old, someone with diabetes, and frequent use of their arms kind of rotating above 90 degrees. So in terms of the symptoms of rotator cuff disease, it's a painful arc of abduction when rotating up 60 to 120 degrees. And so that's one of the tests, the kind of painful arc test. Someone may have pain when they're lying on the shoulder with overhead activity. And weakness may be present with certain resisted motions. Supraspinatus, because of its position, is often one of the ones really that's most torn. There's a drop test. So if someone cannot kind of have their arm fall smoothly down from when it's raised, that's suggestive of a complete tear. So in terms of the continuum, someone may have tendinitis, end up getting a partial thickness tear, full thickness tear and leading to cuff tear arthropathy. And the image showing here is kind of a high riding humerus, which is also suggestive. Physical therapy has the most long-term impact. You can also do subacromial injection, physical therapy, and then sometimes people do need surgical decompression versus arthroscopy. Um, so here is another question. And so I've got some pictures here as well. So I'm going to go ahead and let you answer this one. Okay, great. Let's see. The majority of you answered A, so correct, the proximal long head of the biceps rupture. And you can see there we have the bruising and everything and the kind of Popeye muscle as well. And this is, mechanical injury. And we're going to do one more question and talk more about it. Okay, great. All of you got that right. That's wonderful. Okay, so that's going to be the answer to that one is going to be the shoulder X-ray. So we're talking about shoulder osteoarthritis. Usually people are 50 years or older for primary osteoarthritis. Some of the risk factors are activity and trauma. You can also, and you get kind of this loss of joint space. You may get some osteophytes and some subchondral sclerosis as well. This can be primary. It can also be secondary from inflammatory arthritis, typically reactive arthritis or psoriatic arthritis. It can also be related to metabolic arthritides like hemochromatosis, iron deposition disease. Patients often will have diffuse shoulder pain in limited range of motion. So we tend to get the internal, external, and axillary views, which can show the osteophytes and the kind of joint space narrowing that we saw. So pain management, acetaminophen and NSAIDs, physical and occupational therapy, and of course, some people unfortunately have to go to replacement. Okay, another question for you. Chock full of questions. We have to keep people awake in the morning. All right, let's see. So the majority of people answered A, so that's correct, scaphoid osteonecrosis. And I tried to kind of match the picture from before so you could kind of see what we're looking at with the breakdown of the bones, because I always find that helpful. Of course, it's always very difficult because it's like, yes, you have two hands and they're different positions. And so hopefully that's a little bit helpful. So scaphoid fracture, so that's the symptoms include pain in the radial aspect of the wrist, swelling, and snuff box tenderness. So here's our anatomical snuff box between the extensor pollicis longus and extensor pollicis brevis. Radiographs can initially be negative, but the prevalence of occult fracture is up to 54%. So advanced imaging is helpful and suggested to be done fairly quickly, but if not available, you can repeat the x-rays a few weeks later. So with a good history and physical exam, you can kind of treat as though there's already a fracture, and then the patient should wear a splint. And there's also, so blood supply is distal, and displaced fracture or non-union runs the risk of vascular interruption and osteonecrosis. And of course, you can have a secondary wrist arthritis. So I think especially with that kind of x-rays kind of initially being negative, you want to have a high level of suspicion for this. All right, next question. All right, great. So the majority of you answered B or D. So the answer is going to be the Finkelsteins, and so we'll go over that as well. So the symptoms include pain at the distal end of the radius with gripping and extending the thumb, difficulty using tools. And honestly, this is a common injury we see in Seattle around this time because everybody is out gardening. It's finally some nice weather. So in terms of the signs that you may see, swelling and tenderness at the distal radius, pain with resisted thumb extension. So that's called the Finkelstein maneuver. And so the pathophysiology is you can get these strains or tears from overuse. It's also common with new parents who are kind of holding newborns with their thumb outstretched as well. Treatment includes ice, NSAIDs, stretches, and activity avoidance. You can also inject corticosteroids as well. All right, next question. All right, so there's a bit of a spread with the most people choosing D. Okay, so this is the correct answer. So women more than men, this can occur as osteoarthritis as well. So this is patellofemoral pain or chondromalacia patella. So the symptoms that you have are pain getting up from a sitting position, pain going downstairs. Sometimes people will have a tight IT band or weakened quadriceps with excessive foot pronation. So physical therapy is often very helpful. And then you can do NSAIDs, corticosteroid injection in addition to physical therapy. Okay, so next question. Oh, okay. So quite the spread on this one. So let's talk about this. So the answer is going to be Baker's cyst. So this is what happens is there's fluid from the knee pushed into the bursa behind the knee with walking, and this is often in patients with rheumatoid arthritis, but sometimes with osteoarthritis as well. You can see this on exam. So people have a very firm kind of knot behind their knee. You can see it with ultrasound or MRI. And the best thing to do is to address knee fluid. And so that can be intra-articular injection, aspiration injection, and occasionally surgery. These often do come back, actually. And so what happens is these basically can rupture, and then the person has calf pain with fluid and blood tracking down the leg. So I would say, of course, the kind of hints I think with this one were that the patient has rheumatoid arthritis and knee pain prior to that, but of course you don't want to miss a thromboembolism or anything like that. All right, next question. All right, so quite the spread on this one as well. So let's go through it. So this one is the answer is going to be to wear wider shoes. The most common, this is a Morton's neuroma. So the most common between the third and fourth MTP space. So this is an interdigital neuroma. So perineural fibrosis of branches of the plantar nerve. And so some of the signs and symptoms, so burning pain and numbness into the toes while wearing shoes, especially narrow-toed shoes because you're compressing that neuroma. So there's tenderness and a nodule at the inner space. And there's what's called a Mulder sign, so a click with some transverse loading. So the diagnosis is going to be exam, ultrasound, or MRI if needed, but the first step is going to be to stop causing the compression with the shoes. Okay, so plantar fasciitis is important for us kind of as a mechanical issue, but also part of some of our upcoming inflammatory issues that we'll talk about. So this is the strain of the plantar fascia as it inserts into the medial calcaneus. So this can be due to poor shoes, weight, underlying spondyloarthropathy. And the main thing is heel pain with the first step in the morning or after sitting for a prolonged period. And the pain is localized to the medial inferior calcaneus. So the treatment, so you can use a heel cup, you can do stretches, NSAIDs, and potentially add a posterior night splint if those don't work. Often I'll just tell people to start by, if they're sitting down, to kind of roll their foot over like a can of soup or something, just to kind of stretch the bottom of the heel. And if not improved, walking boot and referral to podiatry. However, I will say, of course, there are some signs or symptoms that we want to, potentially further evaluate for spondyloarthropathy. And so we'll talk about those coming up. All right, next question. All right, a bit of a spread on this one as well. So the most useful next step to look for an Achilles tendon rupture is called the Thompson test. And so overall the differential insertional pain, so you want to think about spondyloarthropathy. If it's mid-tendon pain, you want to think about trauma or overuse. The quinolone antibiotics can affect the Achilles, and if the Achilles is affected, that may rupture up into 30% of the patients who have an affected Achilles. There is still, in terms of the differential, gout, spondyloarthritis, and actually hyperlipidemias. And that's a kind of a picture of hyperlipidemia involvement. The diagnosis, physical exam, ultrasound, MRI, but the tear of the tendon can be diagnosed by performing the Thompson test. So you squeeze the calf and foot, and the foot should plantar flex if the tendon is intact. So the prescription is going to be rest, NSAIDs, immobilization, physical therapy, and surgery. All right, so moving on to all the types of arthritides. We're going to start talking about rheumatoid arthritis. So this is an inflammatory polyarthritis. It affects women more than men. The morning stiffness, because we're thinking in this inflammatory bucket, it's 30 minutes, but often even longer. The kind of initial lab tests are ESR and CRP, looking for inflammation, rheumatoid factor, and CCP, which is also called ACPA. Radiographic changes as well. So we're looking for marginal erosions, which are erosions kind of around the joint, which I'll show you an example of, and osteopenia or low bone, what looks like low bone density kind of around the joint or periarticularly. In terms of where, one of the nice things about the hand is that, not everyone follows these rules perfectly. The patients don't always read the books, but it's very well, certain diseases like certain areas. And so rheumatoid arthritis, we're really thinking across the MCPs and PIPs. So rheumatoid arthritis doesn't typically affect the DIPs, and rheumatoid arthritis also really loves the wrist. So those are the main areas in the hands that you're going to be looking for rheumatoid arthritis. And I think I sprinkled this picture kind of throughout so we could kind of come back to it because I think it's helpful to think in that way. Here's a picture of early rheumatoid arthritis. And so you can see here how these hands are, these two joints, the PIPs, are not all the way flat. You can see how you kind of can't see the lines across them as well, and they look a little swollen. So early arthritis, you're going to see swelling, but typically if you're going to give someone medications, the swelling is going to go down. They're going to have, they're not necessarily going to have joint deformities. So as things progress with rheumatoid arthritis, you can see that people start to collect some joint deformities at times. And so you can just see how swollen these MCPs are, and it's starting to sublux or decrease the fingers are starting to sublux under the MCPs. You can also see just kind of ongoing swelling too. So there's some in the PIPs as well. And then these kind of deformities in the fifth digits bilaterally, which we'll talk about. And so advanced RA, so you can see the complete subluxation over here. One reason why I really like this picture in particular of the hands is that you can see here, in rheumatology, we're always trying to differentiate, how much is old destruction or damage and how much is new inflammation. But you can see here, like you can see the MCPs very well, but here they're kind of very, blunted, and you can see the swelling. So this person has old disease, but also kind of current activity on that as well. And then also you can get toe involvement as well. And sometimes the feet are one of the first places that rheumatoid arthritis can affect. So in terms of the antibodies that we're going to be checking, so we check the rheumatoid factor and anti-CCP, also called ACPA in the literature. The rheumatoid factor recognizes the FC portion of the IgG. The sensitivity is 70 to 80%. Specificity is about 80%. It can occur in other diseases, particularly viral infections and particularly viral infections. And so that's something to really be aware of. If you have a positive rheumatoid factor without the CCP, you also want to have that in your mind that it could be due to something else, and in particular viral infections. For the anti-CCP, this is a post-translational modification of arginine to citrulline that requires this let's see if I can say it right, a peptidylarginine deaminase. The sensitivity is a little bit lower than rheumatoid factor, but the specificity is higher. So you're a little bit more sure someone has rheumatoid arthritis if they have the anti-CCP positivity. And so I would say if they're both positive and the person has, classic disease, you're very confident about that. If they have CCP positivity, you're pretty confident. But if they're both negative, you have to step back and think about other things in the differential. And if it's the rheumatoid factor, you want to think about viral infections. So in terms of rheumatoid arthritis, here are some radiographs showing progressive disease. And so here are some of the things we're looking for. One of the earliest findings is this periarticular osteopenia. So you kind of see this darkened area around the joints, kind of progressing on. You can really see these erosions. So typically it starts in the marginal area. So when you're seeing someone who has early onset RA, you're kind of looking around the sides of the joints because the cartilage protects it right inside of the joints in the beginning. So it kind of starts around the sides, and then over time it really progresses. And then here you can see the subluxation on the radiographs as well, and someone who has quite advanced disease. In terms of the kind of RA treatment evolution, so it's really progressed quite a bit. Methotrexate is still one of our cornerstone drugs, and so that's something that we continue to use today. Combination therapy or triple therapy we'll talk about. And then biologics started coming around the year 2000, and then we started using treat to target. And that's also very important. So for treat to target, what we do as rheumatologists is we have a target for our diseases. So just like in hypertension or diabetes, you have a target that you're trying to reach in terms of numbers. So we have that too. And it's what we do is we kind of assess the patient in the clinic. We look at how active their joints are, and we kind of give them a score. They give themselves a score. And then we come up with the CDI. So it's this number where we can kind of follow it over time and try to get to remission. And so that's our kind of treat to target for rheumatoid arthritis. We are a little bit more aggressive for patients with concerning features. So if they are showing up and they already have erosions, or they have extra-articular features, of which there are many, or a large number of joints involved, we want to be more aggressive. Methotrexate is still our anchor medication after all of this time. And then we routinely monitor the disease activity. They're actually 6 different measures, but which, you know, I don't think is important, but the overall thing to know is that we want to achieve remission and we do have goals. So, in terms of treatment, there are a lot of treatments. I think it can be a little bit overwhelming. So you know, I'm just going to pick out a few as we go through. So we have our conventional DMARDs. Of these, methotrexate is the most important. And we often will combine it with sulfasalazine and hydroxychloroquine for what we call triple therapy. Leflunomide can be substituted. We have this group of anti-TNF agents as well. Those have been around, you know, the longest and are probably the most I think testable in terms of boards since they're kind of so common in a sense. And then we have a few other categories. We have a B-cell agent, rituximab, which we also use for many other things. Many of these drugs we use for many other things. So it's I think good at least getting to know kind of the category, a little bit about the mechanism and side effects. Abatacept or Orencia, and then we have IL-6 inhibitors, and then we have JAK inhibitors as well. So I included just the FDA year of approval as well. So, you know, in terms of trying to reduce the overwhelm, what I did was just throw out some of the major contraindications for each medication because I think that's important and very testable. So methotrexate, you don't want to give it to anyone who has liver dysfunction and it's cleared renally, so you have to be very careful. It's contraindicated in pregnancy. Leflunomide can also affect the liver, but can be used in renal dysfunction, also contraindicated in pregnancy. For TNF inhibitors, it can exacerbate CHF. It's not a complete contraindication. I've used it in those situations, but you just have to be careful. And of course, tuberculosis. So we're always screening patients for tuberculosis. It can reactivate latent tuberculosis. Abatacept, there's a caution with COPD, can increase COPD exacerbations. Tocilizumab, diverticulitis is a contraindication because you can get intestinal perforation. Rituximab, active hepatitis B, including core positive hepatitis B because it may reactivate the hepatitis B. And then the JAK inhibitors, we worry about cardiac disease and thrombosis. And it's something, you know, I wish I could love the JAK inhibitors because it's an oral pill and there's so many people who have, you know, fears of needles and, you know, or difficulty coming in or injecting themselves. And it's an oral medication, but it's just tough because there are black box warnings for all these things. And so we don't often use it, especially in our older patients. So hopefully this helps kind of minimize the overwhelm. I think definitely these are testable and you should know these. We'll talk a little bit more about side effects of the medications as well, but I think knowing the contraindications is good. All right, so let's do another question. Okay, great. So the majority of you chose B, which is the correct answer. So this one is a side effect of the medication. And so the person is on methotrexate, and especially if they are having nausea and vomiting, they may be getting a little bit too much of the methotrexate. And so these are some of the side effects. You can get painful oral ulcers, nausea, vomiting. And so these are some of the important side effects with the medication. Again, I tried to kind of focus on the ones that are important and testable. Of course, you know, you can go crazy with some of these things, but these are the ones most likely to be tested. Plaquenil or hydroxychloroquine. So there are kind of mild and serious side effects. And so retinopathy is one of the serious side effects. And we do screen for that with ophthalmology. Sulfasalazine, we don't use a ton, but we still use it. And so you can get agranulocytosis. Methotrexate, so it can affect the liver. You can get bone marrow suppression, especially if you have too much. You can get pneumonitis and a type of lymphoma that's reversible. TNF inhibition, the biggest thing is TB reactivation. And so that's something that's important to know about. You can also get fungal infections. There's a multiple sclerosis like disease that can cause brain demyelination, which is pretty rare. And then you can get Hep B activation, and also it can cause psoriasis. So that's also something to know. It's a little confusing because it can, it's a treatment for psoriasis and psoriatic arthritis, but it can also cause a psoriatic reaction. And I've seen that as well. And then JAK inhibitors, really it's tough. We worry about heart events, cancer, blood clots, and of course, death. So difficult. In terms of, well, and let's go on to the next one, and we'll keep marching on through. All right. So good, great on this one. You guys are on it. So high resolution CT scan of the chest. So this is some of the extra-articular manifestations of rheumatoid arthritis. Oh, I'm not sure. No, I'm not sure what happened to the ILD picture, but there are two nodule pictures, so you get a double nodule pictures. Rheumatoid nodule, you can see that here, and so that can be a part of rheumatoid arthritis. It can also be exacerbated by methotrexate. So if someone has that and they're on methotrexate, we will often change. You can get scleritis and scleromalacia, and of course ILD. In terms of ILD, so this is about up to 10% of rheumatoid arthritis patients, tends to be more male than female, age in the 50s and 60s. And that makes sense because the onset of rheumatoid arthritis is kind of in the 40s to 60s age range. This usually happens about 5 years into the disease. And a lot of our extra-articular manifestations of rheumatoid arthritis are when patients have high titer rheumatoid arthritis and CCP. Um, the high resolution chest CT is the way to diagnose it, but of course you want to do pulmonary function tests as well. The usual interstitial pneumonitis or UIP is the most common, but there's also non-specific interstitial pneumonitis or NSIP. And the treatment, steroids, mycophenolate, rituximab, and then we sometimes in conjunction with pulmonology will do antifibrotics as well. There's a high rate of mortality. It's second in only to cardiac involvement with rheumatoid arthritis. Rheumatoid arthritis patients have a higher risk of cardiovascular disease in general. So we really try to control some of the cardiovascular risk factors. There may also be pulmonary hypertension related to ILD, and that can contribute to mortality. The UIP pattern has a higher mortality as compared to NSIP. Here are some important kind of RA complications. They're definitely more rare than they used to be, but I've been in practice post fellowship for 10 years. I've seen all of these, so they're still pretty common. Common and not common. So Felty syndrome. So this is leukopenia and splenomegaly. And people may have infections and leg ulcers as well. You can get C1 and C2 subluxation. So rheumatoid arthritis doesn't usually affect the spine, but can affect the cervical spine. So we diagnose that by getting flexion extension views and following that up with an MRI. And sometimes they do need surgical intervention. Septic arthritis. So patients with rheumatoid arthritis are really set up for septic arthritis because they have destruction or damage of their joints. And so they're more likely to get infections. Additionally, they're immunosuppressed. So that kind of adds another layer. You can get tendon ruptures. And so especially the fourth and fifth digit extensor tendons. So those can rupture, and then people are not able, it's kind of in this last picture here, kind of able to lift their fingers up. There can also be rheumatoid vasculitis. So this can be like polyarteritis nodosa, which we'll talk about. So it tends to be more common in men. You can get a foot drop, a wrist drop. You can get skin ulcers and gastrointestinal involvement. Um, so we have these new immune reactive adverse events. So we have a lot of these medications that are being used in various cancers. These checkpoint inhibitors can lead to autoimmune disease, both new autoimmune disease and reactivate existing autoimmune disease. So they're more common with PD-1 and PD-L1 inhibitors than CTLA-4 inhibitors, but the combination leads to a higher risk of immune-related adverse events. And so we see these fairly commonly, and we actually have a separate clinic set up for them to kind of fast track these patients who are having these events. Steroids are mainstay. We also give conventional DMARDs and sometimes other medications like anti-TNF treatments. And then there's always a conversation, between us and the oncologist. Are the patients going to continue these agents, or and we'll treat alongside of it, or are they going to stop? It really depends on kind of the malignancy, what medication is being used, and then what the prognosis is and the alternatives. So there's a bit of a spectrum in terms of what we do. In terms of the rheumatic adverse events with the checkpoint inhibitors, so polyarthralgia, arthralgias or polyarthritis are the most common. So it can mimic rheumatoid arthritis. These tend to be seronegative, so they're not getting those RF and CCP antibodies positive. And about 50% of patients who have pre-existing rheumatoid arthritis may flare on these checkpoint inhibitors. Myositis is less common than rheumatoid arthritis, but it also carries a mortality of 22%. There's a skin rash, dermatomyositis like skin rash, in about 20%. Sometimes patients have ocular disease like ptosis, and they can develop myocarditis. You can also get vasculitis of any size vessel, but especially giant cell arteritis. And then polymyalgia rheumatica, which is similar to idiopathic polymyalgia rheumatica. And so I would say, I'm not part of the IRA clinic, but there's been a fair amount of arthritis that we've seen with these medications. So that's important to know. All right. And then here's another question. All right, great. Okay, everyone got it. I love it. This is a pencil and cup deformity kind of out here. So that's the deformity. And we see that in psoriatic arthritis. So with psoriatic arthritis, it affects men and women equally. About up to 20% of patients with psoriasis will develop psoriatic arthritis. And it has multiple different types of involvement. And so it can involve a few joints or many joints. It can involve the DIPs. And so that's something to kind of be aware of. So whereas rheumatoid arthritis likes the MCPs and the PIPs, psoriatic arthritis likes the DIPs, and it also likes the PIPs. It can be very destructive. So that, we call it arthritis mutilans. It can also affect the sacroiliac joint, so we can get spondylitis. One thing that really, a lot of times psoriatic arthritis isn't that differentiable based on, how it presents to rheumatoid arthritis. It tends to be pretty similar sometimes. But one thing that is different is enthesopathy. And so we sometimes call that a sausage digit, and we don't typically see that in rheumatoid arthritis. So if I see someone with a sausage digit, I'm thinking, okay, that's more likely a spondyloarthritis. And so here is dactylitis over here. And then this is more arthritis mutilans, but you can see just kind of what we would call a sausage digit. So you can kind of compare how this PIP looks to the other ones. You can see the kind of softening of those ridges, and then just how the whole finger is a little bit more swollen. This is more arthritis mutilans, and so you can see just the collapse of those digits, and kind of out here on the left, third DIP as well. So it can be very destructive. The initial treatment is similar to rheumatoid arthritis, which is a relief to us, especially when we're trying to sort everything out. I also have patients with kind of overlapping disease, psoriasis, RF and CCP positive. So it's really nice that the initial treatments tend to be similar. So methotrexate and TNF inhibitors, we tend to use initially. And then we do have a bunch of other things that we can use. So apremilast, which is a PD-4 inhibitor, we often, the nice thing about that is it's an oral pill and it's not thought to be immunosuppressive like the other agents. We sometimes use it in combination. We have secukinumab as well, so an IL-17 inhibitor, and ustekinumab, an IL-12/23 inhibitor, which tends to do a little bit better for skin than joints. And then we have tofacitinib, our JAK inhibitor. So the nice thing too is most of these medications you typically affect or help the joints and the psoriasis, and so that's kind of a nice feature as well. Okay, another question. All right. So glad no one chose D. I didn't actually, one of my colleagues had written that question, but it's pretty funny. Okay. So there's a bit of a spread on this. This one actually, I can definitely see why we'd say palmar plantar pustulosis, but this has a more specific name, the keratoderma blenneragicum. So this is reactive arthritis. And so there are some clinical features. So the joints, with the joints, we see arthritis, dactylitis, and sacroiliitis. With the eyes, we see uveitis and conjunctivitis. So people can have asymptomatic oral ulcers, nail changes, involvement of the penis, and then the soles of the feet as well, keratoderma blenneragicum. So enthesitis, we can also see inflammation at the entheses, so the heels, the ribs, and around the joints. And then also we can have urogenital involvement, urethritis, prostatitis. So this is the one that I think in medical school, what did they say? Can't see, can't pee, can't climb a tree. And so that's kind of reactive arthritis. Okay, so here is another question. All right. So a bit of a spread on this one. Mostly people have chosen A and B. So the next steps would be to start NSAIDs. And so we'll go through and kind of talk about that a little bit. For axial spondyloarthritis, this is a chronic inflammatory disease affecting the sacroiliac joints, spine, and peripheral joints. Often starts in people's 20s. We really don't tend to diagnose people with it once they kind of reach 40. There are a lot of clinical findings, so primarily inflammatory back pain, but people can also have eye involvement, also dactylitis, enthesitis, and aortitis as well. And then let's see. And so, I think the reason why, so a lot of the um, uh, kind of going through this, I think this one was a little bit trickier. So the answer is to start NSAIDs because that's kind of the initial treatment for ankylosing spondylitis. HLA-B27 is a good answer in a sense. It is associated with ankylosing spondylitis or axial spondyloarthritis. However, with HLA-B27, it's not diagnostic, and you kind of already have the diagnosis because the patient has inflammatory back pain and they already have erosion shown at the SI joints. So we really don't need to do more imaging because we already kind of have that answer with the x-rays. And so here is evidence of sacroiliitis. So we get this kind of fuzzy borders in the lower part of the sacroiliac joints. And we can see that in psoriatic arthritis sometimes. And we can also see that in axial spondyloarthritis. Okay, here's another question. All right, so everybody, oh, sorry, I didn't actually. I did not, I apologize. I did not, let's not do this as another question. I'll just answer it and kind of move on. So we have this patient who has kind of swelling of the joints, tenderness and x-ray as shown. So the next steps, NSAIDs and reassure, check CCP, low dose prednisone, or check ferritin level. And the answer is going to be check ferritin level. And the reason why is because what we're thinking is hemochromatosis, and we're looking at these hook-like osteophytes, these bony growths coming off of the second and third MCP, which is pretty characteristic or classic for hemochromatosis. And so what we're thinking about now is we're thinking about osteoarthritis and secondary causes of osteoarthritis. So you can get kind of primary osteoarthritis, or you can get it secondary to something else. Hemochromatosis can be something that kind of exacerbates uh, early osteoarthritis. So if you have odd osteoarthritis or something early that you want to kind of look for other causes. So with osteoarthritis, we've been kind of talking about this, but here's how it looks in the hand. So you get Bouchard's nodes and Heberdine's nodes. You can see how these are kind of bony changes. I think a lot of times it can be a little confusing when we're kind of differentiating this from inflammatory arthritis. Um, Here are some x-ray changes in osteoarthritis. So you get the decrease in joint space, you can see as compared to here, and the kind of sclerosis or the whitish color as well. Here are some of the secondary causes of osteoarthritis. So the question was really about hemochromatosis. And so people have this iron deposition, you get high ferritin, and you get early osteoarthritis. Tends to happen in men or women once they hit menopause because they're kind of holding on to more iron. Acromegaly can cause early osteoarthritis as well. Inflammatory arthritis can cause secondary osteoarthritis. So, it can be secondary to kind of chronic inflammation. Wilson's disease, so an accumulation of copper with resultant joint damage. This is, pretty rare. I haven't actually seen it. I feel like it's been suspected, but this is, another cause of early osteoarthritis. And of course, osteonecrosis. So any damage or collapse of the bone leads to osteoarthritis. And then there's ochronosis, which is really interesting. It's this homogentistic acid accumulation, and people get kind of dark cartilage around the ears and sometimes dark urine. And you can get large joint and early osteoarthritis. Okay. In terms of kind of overall the summary of what to do with osteoarthritis. So you can do non-pharmacologic therapy. You can do bracing, weight loss, exercise. You can have people use a cane, various bracing. And definitely you want to consider physical therapy as well. In terms of pharmacologic therapy, there's oral and topical NSAIDs. You can also do corticosteroids injections, so knees and hips as well. And so there are a lot of things also kind of not recommended by the ACR as well. So these are kind of the main recommendations. The summary is a lot of just kind of pain management, physical activity, things like that. Okay, moving on to, so these are going to be causes of rash and arthritis. So here's our next question, and you can actually see the answers, which is a bonus. All right. So everyone chose D, and it's actually going to be ferritin. And so let me explain that. So this is Still's disease. So Still's disease, you get this high spiking fever, arthralgias, or sometimes arthritis. And so, arthralgia is kind of joint pain. Arthritis is actual inflammation. So swelling, kind of increased heat. You can get this evanescent rash, this rash that basically comes and goes and is a light pink. For the labs, you can get a marked leukocytosis. And so I think there is, often a misperception in rheumatology that, if you see a leukocytosis, it's autoimmune disease, but we actually don't see that very often in most of our diseases. And so this leukocytosis is very notable. Of course, it can go along with infection too, but I think, if we're thinking about parvovirus, this would kind of be pretty abnormal for parvovirus. And then abnormal liver enzymes, you can see, and then typically a very high ferritin. There are not too many things that cause extremely high ferritins. And so Still's disease is one of them. Macrophage activation syndrome, or HLH, is another one. Stills is a diagnosis of exclusion. So by the time we're diagnosing someone with Stills, they've, had a huge infectious workup and cultures and an echo and all sorts of things. It can be associated with macrophage activation syndrome, or which is kind of like HLH. We don't really go into huge detail on those, but that's another kind of cause of high ferritin. The treatment is IL-1 inhibitors, and so canakinumab is FDA approved. All right, gonococcal arthritis, a favorite of the boards. Although I have, I've seen it, so it's not completely, it's not as rare as some of the other things we talk about, but it's an extragenital manifestation of disseminated gonococcal infection. People can get an inflammatory arthritis, commonly of the knee. You can get tenosynovitis, and you can get skin lesions like the one here. In terms of diagnosis, so the culture is not always positive. So you want to do a nucleic acid amplification test. And of course, just test for gonorrhea generally. And then the treatment is going to be ceftriaxone. Parvovirus is another cause of rash and arthritis. So you get this kind of net-like rash, polyarthritis, or arthralgia, which tends to be self-limited, common in kids, but we can get it in adults too. And so we're always doing, a really good history. Lyme disease presents typically months after tick exposure. You can get this rash, erythema migrans, and you get this kind of central clearing. A lot of people don't notice that they were bitten. There's often a monoarticular arthritis, so it's very common actually in the knees. And so that's something that we think about when someone has knee inflammation that's otherwise unexplained. The diagnosis, of course, there's serum antibody testing. The synovial PCR is not necessary, but kind of supports the diagnosis. And typically, if you see an inflamed joint, you're going to take fluids. So it's worth it if you live in a Lyme endemic area. And then the treatment is oral antibiotics. Okay, moving on to crystalline arthritis. So I will give you a second to read the question, and then I'll actually show you the answers. All right, so let's see. The majority of the people chose C, which is the correct answer. So you want to aspirate the knee and send for culture and crystal analysis. And the main reason is because the patient is, has this monoarticular arthritis and inflammation, and you want to make sure that's not infection, but it also helps for diagnosis. So the answer is actually CPPD, or pseudogout. You can see, so things that support the diagnosis are X-ray findings of calcium deposition. It can sometimes be pretty subtle. So here it is in the knee, and you can see that kind of wispy increased calcium deposition, and over here in the wrist as well. But really the way to diagnose it is to aspirate, because sometimes people do have that deposition without actually having active inflammatory disease. It is rare in young adults. It tends to start older. It really likes the wrist a lot, and also the knee. And then the crystals are positively birefringent, and you get these squares or rhomboids. The treatment is similar to gout acutely. And so NSAIDs, steroids, colchicine, and you can evaluate for underlying metabolic disease. And so we have some causes of chondrocalcinosis over here. And then sometimes we'll use NSAIDs or colchicine for prophylaxis. Okay, I'm gonna give you a second to read this and then we'll go on to the next question. All right, so the majority of people got this one. So we're going to treat the acute presentation. So oral prednisone, although the exact dose, it's all over the place. It depends on the patient presentation. But in terms of a kind of acute treatment, that was the correct answer. So this is one of the most common forms of inflammatory arthritis in men over 40, and many people are infected. It's rare in women premenopause. So their first attack may be years after the beginning of hyperuricemia. The first MTP is involved most typically, but any joint can be affected. And a serum uric acid above 6.8 is abnormal. And there's a huge variety in what it actually shows in the various labs, but that's abnormal. And the uric acid level may go down to normal during an attack. So you do want to check the uric acid level kind of outside of an acute attack. So there are a few different treatment kind of things to think about. So one is treatment for acute gout. So NSAIDs, but many of our people can't take them. Oral prednisone to kind of tamp down the acute gout. Intra-articular steroids is great if you know there's not an infection and it's only a joint or two. Colchicine as well. So you do want to start within the first 24 hours or it's not really as effective. And also you're limited by renal disease. Sometimes, especially at our institution, we use anakinra a lot, which is an IL-1 inhibitor, but is not currently FDA approved for acute gout, but very effective. In terms of risk factors, of course, I'm not going to spend a lot of time on this, but you want to talk to people about their risk factors and nutrition, alcohol. And then we get hypouricemic therapy. And so reasons to consider it are multiple attacks per year, of course, tophi, kidney stones, this persistent inflammatory arthritis. We often will start with allopurinol. We have allopurinol, febuxostat, probenecid to decrease hyperuricemia. Lowering the uric acid actually increases the risk of gouty attacks acutely. So anytime you shift the uric acid level, whether it be up or down, sometimes people will have gout flares. So we do use prophylaxis where we give people colchicine, often for about 6 months while we're kind of getting their uric acid under control. And then in terms of our gout guidelines, we have gout guidelines. We typically start with allopurinol, and then we do the prophylaxis. There's a possibility of using pegloticase, which is a uricase inhibitor. However, it's extremely expensive and very time intensive. It's this every 2-week infusion. People have to get uric acid drawn before. It's a mess. It's good, but it's a mess. And then there's this, I think very important to know is this genetic test for patients at risk of hypersensitivity. And so we do often send it in patients of Asian descent, and African American as well. And so that's part of our guidelines because these patients can be at higher risk of allopurinol hypersensitivity, which can be very devastating. All right, I think this is our last question of this one, and then we'll go on to part 2. All right, so you guys are rocking it. Stop colchicine is the correct answer. The patient has some renal dysfunction. It can cause myopathy. Here's just a few more pictures of tophi and some x-rays that include tophi. So it's radiolucent, so you can't see it on the x-rays. Sometimes you will see calcium deposition, and so that's something that you can see on the x-rays, but you get these erosions that are a bit away from the joint. So at rheumatoid arthritis, we tend to see erosions kind of closer, right around the joint line. You can see that with gout, but it tends to also be away from the joint line. So that's one way of distinguishing it. Okay, here, the answer key